and make sure your names are displayed. Your names are visible and videos on. Feel free to use the chat box. We will be coming back to the chat box at specific intervals. Your questions will be taken up at the last of the session so that we don't interfere or disturb the conversation which we are having. And so today we will be focusing on the interdisciplinary collaboration in pediatric palliative care, and we will also discuss few symptoms. And following which we'll have a talk by Joan Marston, where we will be listening to the voice of the seriously ill child. So let's begin by introducing the faculty for the day. We have Dr. Mohammed Ishak, who is experienced in pediatric palliative care, who is a pediatrician by profession. His experience is field of expertise in pediatric palliative care. He's currently the lead consultant in Apollo Cancer Center in Chennai. He has extensive experience in training physicians, nurses, social workers in India and abroad in pediatric palliative care. And he's also faculty for palliative medicine for residents who are doing their MD and DND in India. He's also faculty for International Pediatric Palliative Care Fellows from Philippines, Bangladesh, Nepal, and Sri Lanka. He has done various research and publications in the field of pediatric palliative care. I welcome you, sir, to this online program, and over to you.
Thank you, Sangeeta. So thanks for the introduction. Hello, everyone. It is a pleasure to join you all. Sangeeta, can you share the slides from your end? Am I audible? Am I clear and audible?
Yes, doctor, you're audible.
Yeah.
Sangeet is my colleague who is manning the session from Palliative India. So Sangeet, do we have the slides downloaded?
Yes, we will have. I will share from my side.
Okay, yeah. Thank you so much, Sangeet.
Thank you. So I have come to know that there are around 200 participants, which is great. What I wanted to start with my presentation is I will give a brief about few symptoms and how multidisciplinary teams can help in better management of symptoms in the children whom we take care, both cancer and non-cancer. My network is a bit choppy, so I'll just switch off my video. And like Dr. Sangeeta has said, please put in the chat if there are any questions whatsoever. We'll be happy to have a very interactive session. So, yeah. Okay, I hope, okay, thank you. So, yeah, coming to the topic. Today, we'll be talking about interdisciplinary collaboration in pediatric palliative care symptom management. Next slide, please. So first, talking about what is the difference between a multidisciplinary team and a interdisciplinary. So whenever we talk about interdisciplinary team or multidisciplinary, both are focus and perspective driven. And in an MDT, each member focuses on their own goals, and many a times there is not much cohesion between the care plans each team makes. But in case of an interdisciplinary team, the whole team works with a shared goal, with each team member building on others' expertise. For example, if there is a social worker and if there is a nurse, many a times the care plan that is made, each of them follow that. And like in most of our teams, at least in India, where the resources are not so huge, we don't have each and every team member. So what we do, we tend to share the we share the responsibility as well as, so that is what we are telling about what an interdisciplinary team brings to the symptom management of a child. And like I told, in multidisciplinary teams, they are unable to develop a cohesive care plan, and each team member has his or her own expertise to develop the individual care goal. So as a palliative care team, we work as an interdisciplinary team. For example, in my team, I It is me as a physician, there's a nurse, there's a social worker, and there's a physiotherapist. In many centers where you come from, you might have a child, a play therapist, you might have a chaplain support. And many a times in the place where I work, the new place, I have just a social worker. So we tend to kind of share the responsibilities and follow that uh, proper care plan so that we reach the goal of providing good symptom management. Next slide, please. So today, the objectives would be to give you an idea about how various interdisciplinary teams work together for providing symptom management, such as for pain, respiratory symptoms such as dyspnea, wound management, bleeding, as well as neurological symptoms. So when I talk about a case, just imagine seeing a child who is a 15-year-old who is an young adolescent with osteosarcoma, having a huge mass in his right tibial region, leading to difficulty in walking, difficulty in carrying out his daily activities. There is some bleeding now and then. There is a wound that has developed. And also, the doctors have told that the tumor has spread to the other parts of the body, such as chest. And this adolescent has come to you. So, what is the best way you're going to support him? Just try to formulate an idea in your mind. Next slide, please. So, whenever we talk about assessment of symptoms, like I said, this adolescent has pain and there is a huge swelling on his right tibial region. So, what is the best way we can provide that pain management? For example, any symptom for that matter, any distressing symptom, what we need to keep in mind is the management is done in a stepwise fashion. First, we evaluate and assess. We give treatment for the underlying cause. We want to find what is the main reason why there is pain. It could be nociceptive, it could be neuropathic. And then we would want to put in some integrative as well as rehabilitative therapies together and provide good pharmacological therapy along with non-pharmacological measures. And whenever we talk about any symptom in palliative care, we need to keep in mind that we need to go from history and a proper physical examination. We need to find what was the onset, what was the quality of the symptom, what were the associations of it. We need to know what is the timing of the symptom, whether it is throughout the day or it is during few periods of the day, whether there is any relief in symptom, whether what medications are helping the symptom get relieved, as well as also about any associated symptoms the symptom brings with. For example, in can be sweating, there can be rising temperature, etc. Next slide, please. So before going into more about how interdisciplinary teams can help children with pain, since we have a large group, I just wanted to give a brief about how prevalent pain is in children. Pain is the most common and most widely seen symptom in children who are having serious illness, life-limiting or life-threatening illnesses. For example, these are the various conditions where pain can be seen in children. For example, it could be a chronic or a daily pain in case of a child suffering from juvenile arthritis, child suffering from migraine, various causes of migraine it would be. It could be because of inflammatory bowel disease as well as cystic fibrosis. In cystic fibrosis also many times we feel, oh, why pain? But cystic fibrosis will lead to decrease in bone density leading to bone pains. It can lead to abdominal pain, etc. And what we need to keep in mind is we being in a developing country, children in developing country, many a times they are not having proper access also to having a good pain management as well. They are from various regions. That's why through this program, we are trying to emphasize that pain is very prevalent and each and every physician or any healthcare worker or any volunteer who comes across a child with serious illness needs to ask this basic thing that whether the child is in pain or not. And like we told, in developing countries, since there are a lot of endemic diseases such as malaria, sickle cell, these can cause a lot of pain in children, as well as HIV/AIDS, where it is one of the most common causes of neuropathic pain. Also, many of you might have come across children with cerebral palsy with serious impairment and disability. These children come under severe neurological impairment. So pain in these children, in these group of children, is huge and many a times not well dealt with. There has been a study that around 40% of children have severe to profound impairment of activity, as well as they have been reported to have severe pain. Next slide. So how do you approach pain? There are many ways you can approach pain. For example, you can use an acronym known as Socrates, where S stands for onset, C stands for character, R stands for radiation, A stands for associated symptoms, T stands for timing, E stands for exacerbations or relieving factors, as well as S stands for severity. So this is a way where we are trying to just emphasize that whenever you take a history, you need to keep in mind what all needs to be asked. So this is one acronym that you can use. Another acronym which you can use is PQRST, where P stands for provocation or palliative, a relieving factor. Q stands for quality. R stands for radiation of pain. S stands for severity, and T stands for temporal association. We'll be having a detailed slide about it again. And when we talk about assessment, one main thing we need to keep in mind is we need to educate ourselves about age-appropriate pain assessment tools. So always keep in mind, there are freely available tools. You just need to type it on your phone and you can have that tool in your hand. And always explore the cause. And always think about what are the non-pharmacological management techniques as well as pharmacological. Next slide. And when we talk about management of chronic pain, the best practices is to manage pain with help of a biopsychosocial model. So this is where a interdisciplinary team comes into play. So me as a physician, I can do quite a bit of things, but not only physician, but we need many other healthcare professionals to come together and try to share the main common goal of providing children with good symptom management. So for pain, the best practice is to provide care through a biopsychosocial model, because pain has multiple components just as palliative care, where there could be a psychological component, emotional component, physical component, as well as a spiritual component. And whenever we give a comprehensive biopsychosocial assessment using age and cultural appropriate tools for measuring pain, it can have a very huge impact on the quality of life. Next slide. So whenever we talk about assessment of pain, the most important gold standard of assessment of pain is self-report of pain, which can be done by a child as early as 2 years of age. Many times they can just indicate pain by showing their finger. And the next best thing for children who are not communicating would be a parental report. These are the two things through communication what we can find out. Then there are some scales which can be used for knowing what amount of pain is. For example, we have some behavioral measures. We have some behavioral scales as well as physiological changes scales. Next slide, please. So just I'll go through this slide. So the thing is, like I told, a 2-year-old can report pain. A 4 to 5-year-old can use standardized measure, and a 6 to 7-year-old can have word graphic rating scale. Next slide. So many a times children do come from populations where there is not much of educational background. So this is one scale which we can use. For example, poker chip tool. This can also be used in other children who are able to tell their pain based on the number of chips. For example, 1 chip is nothing but mild pain. 2 and 3 chips are moderate pain, and 4 means severe pain. Next slide. When we talk about children who are able to communicate, we do have a subset of people, children who cannot communicate regarding their pain. So in these children, a revised flag scale is one thing we can use. And a revised flag scale can be used in children who are less than 4 years, as well as children who are not able to communicate. Also, it can be used in children or adults as well who are not able to communicate as well. So the max score in this is 10. Any score more than 7 is known as severe pain or severe discomfort. Next slide. This is another common scale that we use where most of the time one wrong thing which many people do is they see the face of the child and they see the face on the chart and they judge how much pain it is. That is not the way to do. You please show the child and explain that the face on the left hand side means there is no pain and the face on the most right hand side is of severe pain. So just try to explain them so that they can just indicate to us how much amount of pain he or she is having. Next slide. The next scale is numerical rating scale, which can be used in more than 8-year-old, where they can just indicate from 0 to 10 how much pain they have. Next slide. Like we told in assessment regarding PQRST, these are the various components of it. And whenever we talk about PQRST, the other thing is we also want to know how it is affecting their quality of life. Next slide. How it is affecting their mood, mobility, play, appetite, sleep, and what is helping them to get the pain relieved. It could be just doing some massage. It could be just placing the limb in a particular way. Next slide. So who should use this WHO guidelines? So any child or any patient who is suffering from cancer-related pain needs to follow these. The physicians needs to follow these WHO guidelines for appropriate treatment of pain. For other patients who are, for example, who come under the palliative care group, it could be end-stage heart disease, kidney disease, liver, lung disease. It could be children with HIV/AIDS. It could be children with severe life-debilitating cerebral palsy. It could be musculoskeletal disorders, muscular dystrophies, or neurological conditions. What we need to remember is it is not recommended for patients who are having chronic pain who don't come under these categories. So please keep that in mind. Next slide. Coming to the WHO principles of pain, I'm not going to go into detail of the pain medications, just trying to show you what all things are there because all of you do come across a lot of children who are in severe pain. So whenever we talk about principles of pain, we talk about give the treatment by the ladder, by the clock, by the mouth, and individualize. So when we talk about by the ladder, we talk about a 2-step analgesic ladder. We talk about 2-step analgesic ladder. When we talk about by the clock, for example, morphine, if you're giving an immediate release, you have to give every 4th hourly. That's why it is by the clock. By the mouth, we say because it is the most safest route rather than a parenteral route, and also to individualize. So in this slide, you can see initially the WHO pain ladder for children used to be a 3-step ladder, which has been adapted to a 2-step ladder. There's no utility of using weak opioids such as tramadol in a child who's less than 12 years. And many a times you might come across a lot of medical representatives come to you and say, you can use stepentadol, you can use buprenorphine. What you need to keep in mind is there is not much research regarding these medications in lower age group children. So the main medication that we use that I need you all to take home today is about usage of morphine. Morphine is a very safe drug that can be used for children who are having moderate to severe pain. So always keep in mind, if you're coming across any child in severe pain, try to just keep in mind that try to find places where you can send them so that they can go and get that medication for themselves. Next slide. So when we talk about treatment, we need to keep in mind that treatment is not about just giving some medication. That's why we are having this talk, that different healthcare professionals have different roles that they fulfill so that we can provide as a team good symptom management. So when we talk about the art of pain and symptom management, we follow the integrative and rehabilitative therapies. So this includes not only the pharmacological management, but it also involves combining it with supportive, rehabilitative, as well as non-pharmacological therapies. Next slide. So in this, like we told, we follow the biopsychosocial model. There is this multimodal analgesic path which we need to follow, where you can see there are multiple team members. For example, we take support from a family support system, for example, a social worker. We take support from a psychologist. We take some support from our main driving force, that is nothing but our nurses. We take help from anesthetists who might be helpful in providing regional anesthesias whenever there is a need for interventional pain management. Whenever we feel there is a component of spiritual distress, we need to take care, support from maybe chaplains or spiritual leaders. We might need to take support with the help of rehabilitative team by providing maybe occupational therapy, speech therapy. So all these things you can see whenever we are trying to provide good pain management, we need to think about how all the team members can provide that support so that the family and child are supported. So this is something about a multimodal approach, which is an opioid sparing analgesic approach. But what we need to keep in mind, if there is a patient or a child who comes with severe pain, always think about usage of opioids and then trying to also integrate all these other teams together. Next slide. And finally, regarding pain, this is one slide I wanted to share with you. Whenever a child comes with you, uh, whenever a child comes with you for pain treatment with serious illness, always you can follow these kind of steps where you evaluate the patient, you treat the underlying cause. It could be as simple as what do you say, tumor impinging the nerve. Maybe you can use some corticosteroid to just decrease the tumor size. It could be using integrative therapies, such as using music, art, pet therapy, aromatherapy, as well as massage. It could be taking help with the help of our social workers, psychologists, spiritual leaders, as well as child life support uh, people. For example, if there is a child who's suffering from anxiety or depression, you can take help from a psychologist. If there is a child who is disturbed, you can bring them to talk to you with the help of play or by just sitting with them. And all these things you can do. And the next step would be to provide some basic analgesia, usage of opioids, then usage of other adjuvant therapies, and then interventional therapies as well. And finally, at the last, if the symptoms become very intractable and the suffering is profound in end of life, you think about palliative sedation, where you can use propofol, midazolam, as well as morphine. So all these things can be used. So whenever any patient, any child comes with pain, we need to keep in mind that there is always a lot of things we can do. So that is one main reason why we have discussed about pain in detail. The other topics won't be in so much detail here. The next, please go to the next slide. So like I told you, this 15-year-old who has come to you with a huge mass on his right tibial region with a wound, just think about what all we as a team can do. So whenever we talk about interdisciplinary team, we talk about these various components. For example, we talk about a nurse, a social worker, a spiritual counselor. We talk about a wound care specialist. We talk about a psychologist. What we need to keep in mind is many a times in our setups, we might not have someone who's a wound care specialist. A wound care specialist can be a nurse or a physician as well. who's trained in managing wound with various kind of dressings as well as proper who already has some proper hands-on training as well. So let's go discipline by discipline about what all we can do. For example, as a social worker or a psychologist, always keep in mind that whenever there is a wound, there is emotional distress, not only to the patient but also to the family. So we try to assess for the emotional impact of the wound. A child life specialist can involve the patient and family with the help of art, music, play, and also prepare the child whenever and what to expect whenever there is a dressing change. In case of nurses, nurses can provide and educate family about wound care and wound prevention. They can provide information regarding the wound whenever the child goes home. They can educate the family about how to take care. And also, with the help of their hands-on training, they do the best possible dressing changes, medication administration, as well as repositioning of the wounds. As a physician, you are expected to provide good pain relief prior to getting a dressing done, also to train the nurses as well as other healthcare professionals regarding how to take care of a wound. A
So,
psychiatrist.
Can you just maybe your sound is becoming a little bit feeble. Can you hold the mic closer?
Yeah. Am I audible now?
Better, sir. Continue.
Yeah. Thank you. Thanks for telling that. Yeah. And next, other disciplines, for example, if the child, like I told you, he's a 15-year-old, he's an adolescent. He must have had a lot of plans in his life about what he wants to do next. So in this group, there is high likelihood of these children having anxiety disorders or depression, going into depression. And when I say emphasize on adolescent age group, it doesn't mean the other age groups are not having these. The other age groups might also be having this anxiety as well as depression disorders. So always keep in mind, try to keep an open mind about how the child is doing and always try to provide the best possible care which you can. So this was regarding wound. So whenever we have a wound, always try to think if you might not have all the disciplines, but definitely I feel that there can be a nurse, there will be a social worker uh, in your team, or as a physician also. Many a times, a few team members might be missing. But what we can do is we can train ourselves so that we can provide that additional support whenever a particular team member is not there. For example, whenever a social worker is not there, I sit with the family, I talk to them, I try to find out if there is any emotional distress associated with the symptom. It need not only be about wound, it could be about any symptom. So similarly, in our team, we don't have a child life specialist. For that matter, many a times we need to double in as a play therapist or someone who brings in that additional uh, kind of support by providing some music therapy or by just sitting with the family. So what I'm trying to say with this is many a times we might not have all the team members, but if we can just overlap our responsibilities, we can kind of give that interdisciplinary approach to the child as well as family. Next slide, please. So the next is about respiratory symptoms. Again, I felt this is something that needs to be dealt with in detail. That's why we have few slides on dyspnea. So next slide. So whenever we talk about dyspnea, it is a subjective sensation of unpleasant breathing. It is that uncomfortable awareness of one's own breathing. And it is not something that is objective. For example, whenever I go and see a patient, just based on his or her increased respiratory rate, I shouldn't say that, okay, this patient is in dyspnea. Always ask the child whether he or she is having difficulty in breathing. For example, since we are talking about this 15-year-old and we told that this 15-year-old also has mets in his lungs. So just imagine what all symptoms that he can develop in regards with respiratory symptoms. Next slide. So majority of children with cancer and non-cancer conditions do have dyspnea as a predominant symptom during the last weeks of his or her life. And like we told, always whenever we are kind of assessing a symptom, keep in mind what is the history, what is the evaluation, what could be the underlying cause, because many a times the pathophysiology could be multifactorial. In this patient, where we said that there are multiple mets, there could be cotton ball metastasis on all the lung fields or at particular lung fields. So always put a steth, try to find where the breath sounds are, where the child is much more comfortable, because if there is more involvement of the left lung, for example, that patient is much more comfortable whenever he or she is sleeping on the left lateral side. So always try to find the cause and always try to find the uh, assessment part. In this scale, you can see the symptom is graded from 1 to 7, where you can show the child 1 being there is no trouble at all in breathing, and 7 means there is a lot of trouble. So always explain the child what this image depicts, and they can tell you like how much of discomfort they are having. Next slide. Like I told you, always think about treating the underlying cause. For example, in your patient, for example, if you're just putting a steth and listening to the breath sounds, if there is wheezing or rhonchi, it could be some bronchospasm, maybe a bronchodilator would help. Without assessing, we shouldn't ever give any kind of medication. I have seen in practices elsewhere, whenever there is RD or respiratory distress, sorry, they simply just put nebulization, oxygen, they put hydrocortisone, all these all unnecessary treatments can be avoided if we just assess the patient in a proper way. For that matter, for example, if there is any kind of fluid, or if there is what do you say, whenever there is inadvertent IV fluid administration, the lungs can fill up with water, we say, then you can consider diuretics. If there is some kind of an effusion, you can just simply use a proper blood line and you can remove the effusion if it is not loculated. If there are some secretions or the patient is not able to swallow, you can always think about reducing the fluid intake or giving lesser amount of IV fluid. You can also think about using anticholinergics. If the patient is having anemia, and if you feel that the patient is not in end of life and has a couple of months to live with, think about transfusion. If the patient is suffering from anxiety, if he or she is needs some relaxation, you can sit with the patient, you can reposition, you can give some uh, relaxation techniques as well as use of anxiolytics. Also, it could be interpersonal issues. It could be that reason why the child is hyperventilating as well, or it could be spiritual concerns. So always keep in mind, whenever we sit with the child, they do open up. So just give that 5 to 10 minutes for the child so that they can explain what is happening with them, so that we provide the best possible care. Next slide. Like we said, always in any kind of management, think about using a integrative technique as well as a rehabilitative technique. For example, integrative technique, whenever we talk about, think about non-pharmacological measures as well, where you can make the child feel less dyspneic by providing some good circulation of air, by just repositioning. Like I told you, in this child, he had metastasis more predominant on the left side. So a left lateral position or a propped up position would be helpful for better breathing. And also always ask the child which is the most comfortable position. Think about giving skincare, think about using a humidifier, trying to lower the room temperature. Try to keep a window open so that there is good amount of ventilation. Think about non-invasive positive pressure ventilation only if there is still months for the child to live. And also keep in mind, oxygen is not always helpful in case of dyspnea. And whenever we are treating a child with dyspnea, the main thing is improving the subjective symptoms. So if a child is having a respiratory rate of 40, and if it just comes to 32 and the child is comfortable, that is pretty much a good aim to have. So always ask the patient or the child like how he or she is feeling about it, and think about any side effects if there are any with with medications as well. Next slide. And next would be pharmacological interventions. In the next is yeah. There was one more slide about non-pharmacological. Yeah. So in this again, you can see how we can ask them to breathe in and breathe out. For example, whenever we ask them to breathe in, think about smelling the cupcake is something we can say. And whenever blowing out, tell them to blow out as if they're blowing out the candles. Also think about using guided imagery and self-hypnosis. This helps in decreasing the anxiety, which will decrease in uh, making the child more aware of his or her breathing. Next slide. So one main thing I wanted to just emphasize regarding the pharmacological interventions is use of morphine. I know a lot of physicians over here have been asked about how does morphine help. So this slide is for you. You can just take a screenshot and just show to your treating physician that it decreases the perception of dyspnea, it decreases the respiratory drive, thereby helping the child subjectively. Also, it decreases the hyperresponsiveness to hypercapnia. Also, it decreases the oxygen consumption by vasodilating the lungs. Next slide. And opioids, one main thing is these are proper randomized control trials done for morphine, and also giving morphine or opioids is not euthanasia. This is one important thing you need to tell to your team as well. And always have a discussion regarding why you're using this medication for the dyspnea with the families. Next slide. So dosing, just keep in mind you always use half the dose of what medication you're using for pain. So, and one more important point is there is no role of nebulized opioids. Next slide. So the next slide is about what all various interdisciplinary team members that can get involved in case of a care plan. For example, you can use help of a respiratory therapist in regards with talking about what home therapies that can be used at home. You can use services of a nurse to better assess and manage these symptoms. Also talk about non-pharmacological interventions, which we have already dealt with. The physician role is to identify why and what is the cause, try to give proper recommendation about pharmacological and non-pharmacological interventions. A child life therapist, like we told, majorly helps in coping of the symptom with family as well as patient. They can also involve children with the help of play. So if you don't have them, try to do that on your own. You can use help of a psychologist also if there is any anxiety or depression associated with it. You can use a spiritual leader if there is any kind of impact on coping, as well as social worker as well. So all these team members might not be there with you. Always keep in mind, you as a small team can also provide all these services. Next slide. So this same adolescent, now with the wound whichever he had, he now started to have bleeding from it. So there were spurts of bleeding. So whenever there is bleeding, we need to keep in mind it could be a cause of death because of catastrophic bleed. It could also lead to a lot of distress. So we need to give a proper guidance about how to decrease this symptom, and always use medical as well as non-medical techniques. For example, the medical team can prepare the family with the help of preparing, having dark towels, having opioids, having benzodiazepines as a comfort measure, as well as use of tranexamic acid. We need to keep in mind whenever there is an arterial bleed, always have these dark towels so that you can cover them. also provide some pressure, provide some anxiety to the child. If the family member, any family member is becoming anxious, also think about usage of that medication to the family member as well. And please prepare the family always, because if you don't prepare the family, it could scar them for life, because they might just blame themselves that they could have done something but they couldn't. Next slide. So again, as an interdisciplinary team, with the patient and family being at the center of our focus of care, these are the various teams and team members who can help a patient with hematological disorders. I will just move forward because we are short on time. Next, my final slides are about neurological symptoms. You might come across a lot of children with cerebral palsy or children who are having severe neurological impairment. Keep in mind that these are the various roles that uh, the healthcare professionals can fill in so that they can provide good care. For example, if there is a physician or advanced practice provider, they can provide and play an integral role in caring for children with severe neurological impairment. They can help in managing seizures, spasticity, dystonia, neuroirritability. So always, whenever we talk about having advanced practice providers, we talk about providing a good care plan medically and non-pharmacologically to children who are suffering from these debilitating illness. For example, there can be a child who is having seizures at home, comes to the hospital and goes back. So whenever they're going back, make a proper plan about how the medication should be used, how midazolam can be given, how lorazepam can be given, how frequently they can give, and what position they need to be put in whenever there are seizures. Try to mitigate any kind of myths or fears family members are having regarding seizures. So all this needs to be done. When we talk about nursing care, they do form a crucial role in children with severe neurological impairment. They help in assessment of symptomatology. They help in hands-on support with both pharmacological and non-pharmacological techniques. When we talk about taking help from social workers and psychologists, we majorly talk about to know how this symptom is impacting the family as well as the child. We also want to assist the caregivers in better coping and with having anticipated grief as well. And like I told, child life specialists, many a times they might not be there, but if they are there, they do help with trying to bring the child and helping the child in play therapies, as well as trying to just provide some amount of rehabilitative services as well. With this, I end my presentation. Next slide. These are some additional materials which you can learn regarding interdisciplinary palliative care. There are some resources about drug dosages as well as bleeding resource. Next slide. So yeah, any questions? I know this is uh, quite a bit of information for a 40-minute class, but what I wanted to emphasize is whenever you might not have all the team members, but as a physician, you can always double in as a social worker, or you can double in as a person who can inquire about what are the emotional challenges or coping mechanisms. If there is no doctor, if there is a nurse, always a nurse can do a great symptom assessment as well as provide that non-pharmacological approach of pain management or any symptom management. If none of them are there, we want the social workers to get used to inquiring about symptomatology in children. So the main take home point is we as palliative care physicians, we work as a huge team, and these interdisciplinary teams may or may not be there many a times, but we can always work together so that we provide a good care plan and we reach the goals whichever we have formulated for the child and their family. Thank you. Any questions?
Yeah. Thank you so much, sir. There was a question in chat regarding tramadol. Why it is not being used, or can it be used for children less than 12 years? Will it cause seizures?
So the thing is, I know since we are in a setup where many a times we don't have any other opioid and we just have tramadol. Even in my practice, when I was working as a general physician, a general pediatrician, we do used to use tramadol in a child who's 8-year-old, 10-year-old. What we need to emphasize is if there is a child who comes under WHO guidelines of pain management, try to procure opioid. If you're not having an opioid, if you're giving tramadol for that matter, always keep in mind it can reduce seizure threshold. It can lead to seizures. So that is one major reason why we are very particular about not usage of tramadol. But in resource limited countries where we don't have any other option, we do use tramadol with a lot of caution. So it is something that needs to be avoided. But if you don't have any other option, you have exhausted all the resources, maybe then you need to just explain the risks and then give the dose. That is the only thing I would suggest regarding tramadol.
Okay, sir. Thank you. Thank you so much, sir, for taking us through the different interdisciplinary team and the approach that is required, and also for taking in detail regarding the common symptoms that we come across in pediatric palliative care. Next, we move on to our final topic for the program, that is listening to the voices of seriously ill child. For taking this session, I welcome Joan Marston with immense happiness, who is also my mentor. She is a nurse, advocate, manager, and educator who is working in palliative and hospice care for the last 34 years at local, national, and global level, with a focus on children's palliative care and more recently, palliative care in humanitarian settings. She is a vice president of Elizabeth Kubler-Ross Foundation Global. She is a co-founder, first chair, and CEO of ICPCN, which is International Children's Palliative Care Network, and presently a global ambassador for the ICPCN. She's a co-founder, executive committee member responsible for advocacy on PALCHASE, that is palliative care in humanitarian aid situations and emergencies. She's a founder of St. Nicholas, now known as Sunflower Children's Hospice in South Africa, which was founded in 1998. And she's also on the management team. She's experienced in envisioning, settling up, and managing palliative care organization at all levels, from a local hospice to a national and international network, advocacy and networking, education, fundraising, strategic planning, and project management at local, national, and international level. She's passionate about palliative care, children, and vulnerable population, especially in humanitarian settings. So I once again welcome you, John, and over to you.
Thank you so much, Sangeeta. And thank you, Dr. Mohammed, for really setting the scene for my presentation now. I wonder, can I control my own presentation? Can I share the screen?
Yes, Joan, you do have the access.
Do I have the
know if
access?
you need any assistance.
Okay, it's not allowing me to share the screen.
You are already co-host, so do you have?
Here we go. There we go. Thank you. Right, so I really am privileged to talk today about listening to the voice of the seriously ill child. And I think the presentation that Dr. Mohammed gave shows you how many barriers there can be when we are listening to the children that we care for. And so today in this short session, I just want to cover some principles about how children communicate, because how they communicate is going to impact on how we listen, the internal and external influences to that communication, and how we need to develop our capacity to listen and respond. And then throughout, I'm going to weave children's stories of children that I've cared for over the years. And these are all given with the family's permission for the children. So when we set up the International Children's Palliative Care Network in 2005 in Seoul, we actually ended the founding statement with, we ask that the voice of these children and young people is heard, respected, and acknowledged. So you can see right from the beginning of the international network, we were talking about the voice of the child. And of course, children speak with many types of voices. It's not only the spoken word. They may use words. Yes, they do. They tell us things. They might tell stories, and basically everything they do is a story. They use their body, whether it's body language in retracting from you, coming forward, or whether it's in dance, facial expressions, the tone of their voice, art, song, poetry, and dance, but most especially with younger children, they communicate through play. And so you can see we have to be able to listen to all those different voices that children do use. And so when we talk about words that they use, it is all those other forms of expression that I have mentioned. And when they are expressing themselves, for us to listen to them, there is a message. There's meaning in that message. So the spiritual aspects are already coming through. And they use a different mode. One time it might be a facial expression. This is my little godson, Booty. He came to us, HIV, severely malnourished, very, very neglected. He's never been able to talk, but he expresses himself with his face and his eyes and the way he reaches out. And then, of course, the context, because we all talk and listen within a context, which is impacted by so many different factors. And children are very imaginative. They love using their imagination. They love the stories that are filled with imagination. Just think of Harry Potter. And so they're very influenced by what is going on inside their head, in their imagination. And that's why it's so important for us to be truthful and honest with these children, because if we don't, they're going to imagine things that really can be very unpleasant and distressing. They're influenced by memories, what has happened, and the way they respond to you might be because the last time they asked an important question for them, you said, oh, you mustn't think about that, or we don't talk about that, or I'll speak about that tomorrow. The emotions that they're feeling, these are children who are seriously ill. And of course, they are caught up in a complex network of emotions within a network of emotions of their family as well. Then their experiences, which will come according to their age and their developmental stage, and the impact of culture. I actually had a workshop on communication this morning, and we were talking about the different cultures within South Africa and how within my culture, children will speak freely, and within another culture, children are more reserved because they are expected to listen to what the elders say. And then, of course, our beliefs. So what we believe in, what we as adults bring across to the children, the beliefs that they are brought up in as well. All of these things are going to influence what they say, how they express themselves, and of course, then how we listen to them. And then often within their communication, there are hidden messages. So much of their communication is centered on loss, and the response to loss is grief. So we need to remember, if a child is old enough to love and to be attached to someone or something, including themselves, the image they have of themselves, that child who could dance, the child who could play football or cricket. And when they lose that through their illness, they are grieving. And we might not see it as grief. We might see it as they're not interested anymore, they don't talk about it, so they're not thinking about it, but actually they're grieving that loss inside. So if they're old enough to love, they are old enough to grieve. And children love at a very, very young age. They also have a hidden message of protection, especially the silence around their parents. They're not talking or questioning because they're worried that someone else will be hurt by what they ask or what they say. And that's especially parents. And we have to watch out for mutual protection. Where the child knows something and the adults know something, and they don't talk to each other because they don't want to hurt each other. But actually, by not talking, they are hurting each other even more. And often there is a question beneath the question. So when a child is asking, am I going to get better? The question beneath that might be, am I going to die? But they don't want to use that word. So they use something that is a little bit softer. Am I going to get better? And the silence. Silence is in itself communication. But often the thought, if I don't talk about it, if I don't ask about it, it won't happen. And so let's rather avoid it. And children often go through, seriously ill children often go through these stages, understanding from being, I'm sick, but I'm going to get better. I keep on getting sick, but I'm going to get better each time. I'm going to keep on getting sick and I won't get better, or I don't seem to be getting better, until many of them have that final understanding, I'm going to die. And when they're going through these later stages, they actually need to have someone to talk to. How do they talk to us if we don't listen deeply and listen with all our senses? And one of the great questions that we so often get with these children is, will you remember me? And this is our wall of remembrance at Sunflower House, where we remember them, and they know that. Their name goes on the wall. They sometimes choose their own flower, or they want to know about another child, which enables them then to actually talk about their own illness. So they might say, who was Tabu? And I'll tell them about Tabu. And they say, but Tabu had the same sickness as me. And I'll say, yes. And then that opens the conversation. And this is in their playground. So it's part of death, is part of life. But we must also remember that within their questioning, within their statements, there always remains that hope. The hope that they'll be able to play football again. They'll be able to play with friends. The hope that they're going to be comfortable, that their symptoms are going to be controlled. The hope that everything is going to go back to what it was, and we never take that hope away. So where do we begin when we listen to the children? We begin with ourselves, because if we aren't right, we're not going to hear what they're saying, and we're not going to be able to listen with absolute attention and listen generously. So we begin that long journey into ourselves when we're working with children. And I love this quote from Rumi. So ask yourself, how well do you as a person listen when a child is talking to you? Watch your friends, watch other people when a child pulls their clothes and they want to talk, but they're saying, I'm busy, later. How carefully do you observe? Because if children are talking with their body and their face and their other movements, we've got to observe all of that. And then, of course, that instinct. The child is telling you one story, but actually your heart tells you there's another message deeper there. And we need to be listening to our own hearts and our own instincts. And then we need to be aware that we come to them in our own context. And our contexts contain our beliefs, our knowledge. And it's important to have knowledge when we're working with these children. We need to understand what are the different stages of childhood development, understanding, development of spirituality. All of these aspects are important if we're going to work with these children and truly listen. And what is our willingness to learn? Sister Frances Dominica, that great pioneer of children's palliative care and the founder of the first hospice, has always said, the child is the teacher. We are the pupils, and every child is a masterclass. So we need to be open when that child is is talking to us, to listen and to learn. So we need to have all that knowledge, as I've said. We need to be able to get down to their level physically. Well, if you can, some people can't, but as low as you can get to try and get onto their level. We might want to use an object of transference, a toy, a puppet, a book, a ball, bubbles, a teddy bear. I like puppets. I love balls because balls are a wonderful, safe form of connection. And I find wherever I go in the world, children love bubbles. And really importantly is how you present yourself. Smile, speak gently, be compassionate, maintain contact. And if you don't have a puppet, well, take an old sock. It's really quite easy to do. I have my favorite puppets and I use different ones for different children, but actually the sock works just as well and children find it quite fun. And we need to also remember, if we understand spirituality about being about meaning and purpose and connectedness to ourselves, to others, to nature, to God or the sacred, however we perceive them, then these statements and these questions that we get from seriously ill children are actually spiritual interactions. So we need to be comfortable with our own spirituality, and we need to have an understanding of children's spirituality as well. So I just want to tell you two short stories. These are two little boys who came into Sunflower House, our children's hospice, at the same time. They were both HIV positive. They both had multiple infections and they both had heart failure. Stimbili, the little boy on the left, they were both orphaned as well. He was a little man of very few words. Even though he was 3, his vocabulary was really tiny, but he could communicate with his eyes, with his face, and with his hands and arms. He had the most expressive hands and arms. And when he was there, he found a big brother in Godfrey. Godfrey was 12. He'd had a really rough sort of life. He'd actually become HIV positive, living on the streets. And again, he had heart failure, but he responded very well to treatment, whereas Stimbili didn't. But these two developed a real connection. They were two brothers together in the house at the same time. Godfrey loved to draw. He was our artist. Then little Stembi, he got sick. And he was terminal. He was near the end. He was on a bit of oxygen. And I went in one day, we were going to take Godfrey to buy clothing. And he looked at me while I was sitting at the bed, and I picked him up and cuddled him. He pointed to the door, so I took him to the door. He saw my car, so I took him. I said, do you want to go for a drive? And he nodded. So we went for a drive. And on the way back, he showed me all the places, as we drove past them, all the places that he wanted to stop and go to. These were places, these were his favorite places. And when we got back to the house, he started to cry and he pointed to the door and he pointed to the car. And with the very few words that he had, he told me who he wanted to visit. And so we visited his friends. We visited his favorite places. That night he wanted to go outside and he pointed to the sky and he said, Stembi, as though he was saying Stembi star. And Stembi died. Godfrey was very distressed, but his health was really doing well. But then suddenly his art changed from drawing houses and people. He started drawing swings. And in the beginning, the swings had children on them, and then one swing didn't have a child. And we thought that was Stembili's swing because Stembi had gone. And so we said, Godfrey, why is that swing empty? And he said, that's my swing. And we said, why is that your swing? He said, because I'm not going to be there swinging much. And we thought maybe he was thinking of going home. Then he started giving all of us pictures of cars and trucks and aeroplanes. And what we discovered, that even though none of us thought that he was actually going to die at that time, he'd responded so well that he was trying to tell us that he knew he was going to die. So both of these children, in their different ways, and he died unexpectedly and shocked us all, but he knew more than we did. So Stembi had unfinished business to complete, and he made sure that he'd seen all his favorite people and places. And so we remembered him with Stembi's star. Godfrey, he used art and he used words because he told some of us that he was going to die. He gave pictures of vehicles to show he was going on a journey. And he showed us that he was no longer going to be on his swing. So these were two children who communicated in different ways, but the use of words was very, very limited. And how could they do this? What was essential in those situations? The children trusted the staff that they spoke to. The staff were trained and experienced in the languages of childhood. So they knew that when Stembi was showing something, what he was saying, the art, they knew to ask the questions. And something really important, they were guided by the child. They didn't try to impose their perceptions. And they weren't afraid of being present, of being there with the child. And that is so important. And then they responded with honesty and didn't avoid responding to the child's awareness of dying. So both of those children were able to complete what they needed to do before they died. And I think these three factors are very important. One is that we have to be a presence. We have to have the time and the patience to be present, fully present for the child. It's the child who's facing this overpowering illness, and we have to give them time. But it's that relationship of trust that enables them to talk to us. And sometimes children find it easier when they're together with their friends, doing activities, drawing, singing together. And when one opens up about how they're feeling, then the others think, well, that's okay, I can do it too. And of course, here in Africa, we have a concept called Ubuntu. A person is a person because of other people. And so when I'm with other people, I can be more fully myself. And this is another example of that. These three little ones, we was in the garden, they were playing, and the three of them came up to me holding hands and said, Sister Joan, they all call me Sister Joan, what does it mean to be dead? So how do we answer those kind of questions? What does it mean to be dead? Am I dying? Am I going to die? Am I going to get better? What's happening to me? It's really important that we never give an answer without asking questions. Dancing is also something that can tell us a message, especially with our teenagers. One subject that we often don't like to talk about is sexuality. And yet for our teens, often the message about that sexuality that they can't talk about because people are uncomfortable comes through in their dancing. And so when they dance, you can afterwards say, that was a wonderful dance. Were you trying to tell me something? So what do we do? Begin with gentle questioning. Clarify, clarify, clarify. Know what they mean, but let the child be in control. And you can ask things that made you think of that. Why did you ask that? What do you think? How did that make you feel? Again, reflecting back, letting the child be in control. Would you like to talk about it some more? And this is a wonderful example. I'm not going to read it all to you, but it was a little boy who wrote to Elizabeth Kubler-Ross, who he'd met at an airport, and he said, why won't anyone talk to me about dying? He was 10, he had cancer, and she used the image of nature, about seeds that are planted and how those seeds grow, and they flower in the summer, and in the harvest they fall, and about death that comes early to some and later to others. And then she talked about how children and adults, first of all, They complete what they need to do, and some complete it very quickly. Might be an hour, it might be a day, and others might live like a great tree to an age. But I do urge you to read the Dougie letter. It is beautifully done, and it gives you real good guidance. So in summary, always be guided by the child. Always clarify. Don't assume. If they come and talk to you about death or dying, they might have seen a dead bird in the garden. They mightn't be asking about their own death, and you start talking to them about their own dying, and actually they want to know, why is the bird dead? Ask questions, gentle questions, simple questions at their pace. Remember, little children, their concentration is very short. So they might come backwards and forwards, and you start talking and they'll go off and play because they've had enough. That's it. Stop when they want to stop. Don't force them to carry on. And always, always, always be a gentle, compassionate presence. And so the way that we can support these children is on the second Friday of October every year, is to put on a hat to show that we are raising awareness and we support these children with palliative care needs. And one of the best ways that we can do it is to listen to them. And just a couple of helpful resources, and there are many, many, many resources out there, so I do encourage you to use them. The online ones are the International Children's Palliative Care Network. There are a lot of free e-learning courses. They are all ratified by the University of South Wales, and then the Elizabeth Kubler-Ross Foundation, which runs educational courses and is very generous in supporting people from low and middle income countries as well. So those are just a few real tips about it. There's a lot more to learn. There's so much to do. But if we remember that the child is the teacher, we are the learners. And whenever you meet a child, if you listen carefully, you listen for what they say, what they mean, and you learn how to respond to them, that you will actually grow. And you will develop your own expertise. That is the gift that the children give to us. So thank you very much. And if you have any questions, I'm happy to try to answer them. Otherwise, I'll find a child to answer for you.
Thank you so much, John, for taking us through, the importance of listening to the seriously ill child. Quite often during that emotional disturbances situation, we just focus on the parents, or sometimes we try to focus on, dealing with the physical problems of the children. We don't even find time to talk to them. So it is really important what they understand about their condition and how they are dealing with it, internally. So thank you for teaching us the importance of that. And now I understand this pediatric palliative care is in fact a vast topic, and it is difficult to cover all this on an online platform with time constraints. So you'll have a lot of doubts and maybe you need clarification as well. With this thought, we came up with a conclusion that an offline program, a workshop, will be helpful for all of you. And so we are planning to conduct a 2-day offline program workshop in this coming December. Can I have the sharing rights? Yeah.
You already have.
Yes. So yeah, so we are planning to conduct the offline program in this coming December on 9th and 10th of December 2023. It will be conducted in the Child Development Center in Sri Avatam Tirunal Hospital at Thiruvananthapuram. And we will have national and international faculties who will be taking the sessions. The workshop is mainly focusing for the doctors, nurses, physiotherapists, and the medical social workers. And we charge a very minimal amount of ₹500 for the workshop. And this is roughly the topics that we are planning to cover in the workshop. So it is introduction to pediatric palliative care, pain management in children will be taken in detail, the end of life care and spirituality, the role of nurses in pediatric palliative care, withholding and withdrawal of life support in children, the ethical and legal perspectives, death and dying in children, the role of physiotherapists and volunteers in pediatric palliative care, grief and bereavement, communication with children, and in detail, we'll have case discussions as well. So this is the plan for the December workshop. So I hope all of you can join our offline program and have detailed interaction with our faculties and clarify your doubts. With the online program, definitely we'll have some time constraints, and I don't know how effectively we can, clarify all those doubts. So that's why we are planning to go ahead with the offline workshop. So the details of the workshop will be shared through the online platforms, and also you'll get it in the WhatsApp group in which you have already joined. So make use of the opportunity where you can directly talk and clarify your doubts with the eminent faculties. So yeah, that's it. If you have any doubts, you can definitely go ahead and clarify. Over to you, Sripriya.
Thank you, Dr. Ishak, and thank you, Jan, for motivating us with this wonderful slides. So now the forum is open for any burning questions, queries which you will be having. You can raise your hand so that we can unmute you from our end. Because presently we have disabled the option of unmuting. So if anyone wants to speak up, please do raise your hands.
I see there is a question in the chat regarding the how to deal with the parents who want to conceal the diagnosis and prognosis from the children. John, you can take it.
Yes, I think that is something that I have seen so often. And I apologize, there are geese in the garden, so you might hear them honking in the background. First of all, you've got to find out you've got to talk to the parents first. Why do they want to conceal it? And of course, it's always a protective thing. And then they'll often say to me, but you mustn't talk to the children about dying. And my answer is always, I won't tell them they're dying, but if they talk to me about it, then I'll have to be open and honest with them, because if I'm not honest, they're not going to trust me. But really, it's working with the parents. Parents are battling. Who wants to see their child die? And usually if you spend time with the parents and then you promise, I'm not going to go in and say, little Johnny, you're going to die. But if Johnny says to me, I think I'm going to die, then I'm going to allow the conversation. But it takes a bit of time. And you've got to be totally empathetic with the parents. It is a very, very difficult thing for a parent to even accept that their child is going to die, but to tell them is very difficult. But I've really found that if you spend the time, the parents come around, and as long as they can see that you do it very gently, they will accept it. But it does take time. And I see there was also a question about preparing ourselves mentally in palliative care with the dying children. So perhaps I can just say that. I think it's something, when you're working in the field of dying, or for all of us, it is a spiritual experience. And I think the best thing that we can do for ourselves to help ourselves is to work on our own spirituality, to understand ourselves, to give ourselves time out, to be gentle with ourselves. So it hurts and it's sad, to deal with that as well, and to do things that just take us away from the sadness. And I think for myself, it comes from my own religious beliefs as well, and beliefs in what happens and who's in control. but I think for each and every one of us, working on ourselves, giving time for ourselves, time to build our own spirituality is certainly what's helped me over the years. And working with these children, they are so resilient and beautiful. It's a privilege.
I could see a couple of questions regarding the on-site workshop. So kindly be informed that the details of the session will be shared in the group. The venue is in Trivandrum, Thiruvananthapuram, the district in Kerala. So the remaining details will be shared in the group. Dr. Sunil and Dr. Sangeeta, I believe Dr. Narayanan has put up a suggestion that can we make the offline workshop a hybrid one so that people from other cities also can participate.
Yes, sir, we are planning for that, but we are also in the initial stages of, working it out how we can do it. And the details, of course, will be shared. We'll keep that suggestion in mind and let you know soon, sir.
I can see the hand of Mr. Samir raised. Samir, you can unmute.
Hi, I'm a counselor working in palliative field itself. And so my question is with respect to are there any spiritual or behavioral or psychological sort of signs or symptoms, sort of expressions in which or ways of in which the child may sort of communicate that their time has come? I think one, Joan itself presented in her case study that the child expressed it in his artwork, saying that there was he won't be there through the swing, and so I'm just wondering what are the ways we can sort of identify, because there are times when child passes away suddenly and it's not really expected, and so yeah.
Yes, I can only talk from the experiences that I've had. And so it's not every child who will show you that they know that they're dying. I ran a workshop this morning and I had one of the mothers who, when we were talking, she said, she'd lost 2 children who died of cancer, 2 little girls. And she said with the second child, she actually sent her mother away. And she realized afterwards that she was protecting her mother. She didn't want her mother to be there when she died. But I've seen with many children in their art, in just the simple words that they might say to you, I think I'm dying. I'm going to die soon. It's building that relationship. You don't always have time. If you're working in a hospital, it can be very difficult. We have the beauty of working in a hospice and working in the community. Is if you build that relationship, is that the child knows that they're getting weaker. They know they can't do things that they used to do. They know they can't eat. They know that they've stopped their chemotherapy. We tend to forget that even very young children have insight. Little Stembele, who wanted to say goodbye to everybody and go to his favorite places. He knew he was dying and he was only 3. So it's really building a relationship with the child, getting to know the child so that they can express to you, and being aware when that child tells a story, when they draw a picture, and you look at it and you think, ask them. So you're trying to tell me something. I think you're trying to tell me something, but I think I'm a little bit dim. I can't quite get it. Will you tell it to me? Or tell me a story about that dance that you just did. I saw you were playing just now. What was that game you were playing? If you give the child the opportunity and they can respond, then the majority will respond. They want to talk about it.
Yes, Palash. If it is the same query which you had put in the chat, please speak up. Like, kindly unmute and
Hello,
yes, you are audible.
ma'am. My question to Madam John, that is, I'm general physician, but in my OPD practice also, different type of patient, pediatrics to geriatrics, everyone has to come. So the thing is that listening to the voice of children is fine, but expression is difficult. So what is the principle to deal with this pediatric palliative care for the healthcare providers? Can you highlight or emphasis on that point?
I'm sorry, is it about the expression is difficult for the child or for you as the healthcare provider?
Yes, difficult for the healthcare provider.
Yeah, I think that's why I say it's something that needs, if you really want to do it and want to do it well, it needs preparation. It needs for you to do that introspection with yourself. It needs for you to learn about what ways are the children communicate, and also how they express themselves at different ages and different developmental stages and understanding. So it needs that good knowledge of childhood development. And then it also needs a space, because in a busy OPD clinic, in a busy ward, it's noise and you don't have much time with each patient. And how can you create a space? It might be a little play corner. It might just be sitting outside with the child for a little while. I find taking them into nature, getting them out in the garden is actually very good. It might be just sitting and playing for a few minutes to build a connection. And using each child as your teacher, because if I think some of the things that I missed in the early days, and I'm sure I still miss, it's just learning all the time. So I don't think there's no simple answer to that. It's just the minute that you become aware is the minute that you will start developing your skills in hearing what the child is trying to say. And maybe simply just saying to the child, is there something important you'd like to talk to me about? Would you like to tell me something when mommy's not here? Because sometimes the child wants to talk, but they don't want to upset mommy. So it might, but every child, I don't know if somebody else here would like to say from their own experience. Dr. Mohammed, you have great experience. Would you like to answer that as well?
Thank you, ma'am. Ma'am, my question is that in interdisciplinary collaboration, who will be the spokesperson?
The one that the child connects to the best. You know, and it might be the chaplain or the pastoral care, it might be the social worker, the doctor. For me, if you're working in an interdisciplinary team, it's to see where the best connection is, and to allow that, not to try and pull the child in all directions. He's got to speak to the social worker and the pastoral care, the doctor, see who that child connects with naturally, and let that person be the spokesperson.
Treating physician or counselor will be the spokesperson or deal with this thing?
I think everyone needs the skills. When you're going in depth, you would probably use your counselor, your child life specialist, your psychologist, perhaps a social worker. Yeah. But as I say, sometimes, in a hospital, the child will speak to the cleaner, because the cleaner is a motherly figure and the child finds it easier. So I think if you're working in the team, we would ask the psychologist or the counselor, or if you have what we call a chaplain or a spiritual counselor there. But in I work in a low resourced setting, And as Dr. Tayub spoke about earlier, often you have to be all of those people in one. But if you have counselors, it's wonderful. They have more time. The physician is looking after the clinical aspect, and then to send them to the counselor, as long as the counselor knows how to talk to children and how to listen to children. Some people are brilliant with adults, but not so good with children.
Thanks a lot, ma'am. Thanks a lot.
So I'm sure there are a lot of questions coming regarding, especially in the communication part. Like, ma'am, sometimes parents don't want to interact with their child. How should we deal in that situation? So
I think
it takes, yeah. Yeah, John, you can go ahead.
No, I was just saying it's when you said they don't want to interact, they don't want to interact directly with their own child, or they don't want to talk about death and dying with the child. And so that often, if they don't want to talk about the illness and about the dying with the child, is first of all having a relationship with both groups, and then trying to persuade the parents that you can say to the parents, but your child knows that he's dying. He knows he's very ill. He knows that the chance is good that he's not going to get better. And he talks to me about it, but I think he really wants to talk to you, and you can coordinate. Sometimes, would you like me to be there? I can sit with you when the first time you talk about it and take it from there. But every situation is different, and you just have to be open and sensitive to what the needs are. And it's the parents that don't want their child to die. So if they don't talk about it to him, maybe it'll get better. It's that hope. That's why I say hope is that overriding rainbow over everything.
Yeah, definitely we need more detailed discussion and more detailed understanding regarding this topic. And hopefully our offline program in December 9th and 10th in Trivandrum, Kerala will be helpful. So I'm inviting each and everyone who is attending the session to be a part of our offline program in December. The details, registration, and everything related to that will be shared in the WhatsApp group and also in other online platforms. So keep in touch with our technical department. They'll keep you posted. And with that, we come to the end of the program. And it was really a successful and wonderful interactive session with everyone. All the faculties have given their, detailed their expertise in this area, and hope all of you, those who have attended both the sessions, have benefited from it. And for the participants who have attended both the sessions, will be given the certificate for participation. And yeah, that's it. Thank you everyone for making it a wonderful, successful online program. With that, I hand over to Sri Priya.
Thank you, Dr. Sangeeta. Thank you, John, and thank you, Dr. Mohammed Ishak, once again. And thank you each and every one of the participants for making the session interactive. Yes, we all know pediatric palliative care is a very sensitive thing and very hard to handle also sometimes, because I have seen Dr. Sangeeta handling very beautifully, kids very beautifully at our settings. So we hope that this small webinar had made your knowledge, your awareness about this particular topic more, and we wish that some of you at least become more interested in pursuing more knowledge in the topic, and assuring that we will always be there to support you in the mission. This is Sri Priya, along with all the eminent faculties and speakers, and Dr. Sangeeta Suresh, signing off from the Palliative India's desk. Keep connected with us for more updates. Till then, everyone, take care. Bye-bye.